Welcome to Scrubcast, where we take a closer look at the research happening at Stanford University's Department of Surgery. I'm your host, Rachel Baker. Today, we're speaking with Dr. Stephan Busque. Welcome to the show.
Well, thank you very much for an invitation.
Thank you for joining us. It is wonderful to have you here. Dr. Busque, you are a professor in our Division of Abdominal Transplantation and a Canadian. How did you end up at Stanford?
Yeah, you're right. I'm a Canadian. Actually, to be more precise, French-Canadian or Québécois, if you wish. But I'm an American citizen. How it started, born in Montreal, did medical school there, surgical training, and some research in immunology, both on the French side and at University of Montreal and at McGill. And then I was interested in a transplant and I did my clinical fellowship in the United States. So I'm following a bit what my mentors did in Montreal. So Dr. Dalloz, Dr. Cormand, they trained actually with Starzl in the late 60s and brought transplant to Canada. So I followed their lead, trained at the best center in the United States. I was interested by the West Coast. I ended up interviewing at the California Pacific Medical Center, where Dr. Carlos Esquivel was leading the liver transplant program, a trainee of Starzl himself, and also Oscar Salvatierra and other great pioneers of transplant, Dr. Jeff Collins. And then I moved back to Montreal after that training. At the same time, they moved their practice from the California Pacific Medical Center to Stanford. So 6 years later, there was an opportunity and they called me back. And I was very interested to be able to join what I would say be drafted in the major league. And so that's history now. That's 25 years ago.
Amazing. Well, why did you choose transplant?
So first, to understand this or my track, you have to understand that there's two of us. I have an identical twin brother. So
No way.
both interested in medicine and in surgery. And at some point, not able to make up our choice between going into the direction of a surgical career or a medical specialty career. So my last rotation as a medical student in surgery was with the team doing transplant. And then after a week, it was like clear, an epiphany. It's like, oh, this is the best of the surgery and still the best of medicine. So it's about clear cut. It was my career choice. And my twin brother decided to go in direction of hematology and bone marrow transplant. So, at some point, the Busque brothers had to be separated.
Very interesting. So your research centers on immunosuppression after transplant. We know that transplant recipients receive medication to repress their immune system so that they don't reject the new organ. Your immune system knows that it's not your organ, wants to kick it out, even though it's keeping you alive. So these meds, while they let you keep the organ, they create their own host of issues. Is that correct?
Yeah, absolutely. So these meds have saved thousands of lives. And partially that we're better at it and they're improved, so people live longer. So we are able to now have a better assessment of what is the burden of immunosuppression. What does it do? So we are more successful early on. I'm giving the example of kidney transplant, but then with
Mm-hmm.
time, the diabetes, the effect on the cardiovascular system, toxic to kidney takes a toll. And then
Yeah.
what's gained upfront is not as sustained. And, just to illustrate this, I don't know if you're aware of the essay that Amy Silverstein wrote in the New York Times maybe 3 years ago. So Amy Silverstein, who was a correspondent for the New York Times, got 2 heart transplants during her life. But she's a good
Wow.
example of what is still imperfect in our field. So her first transplant, despite all the medication, rejected. So she needed a second one. She did very well. And then she developed a complication, a lethal complication of immunosuppression years later, which is lung cancer. So her essay title was Me and My Heart Will Die Soon. And that she published this like a couple months before her passing. She was
Wow.
very grateful for the extended life that the transplant gave her. But she pointed out that there's not a lot that is done in terms of research to reduce the burden of immunosuppression. So it's kind of like a cry for help to try to help, stimulate research in that area for other transplant recipients. Actually, this is what we do at Stanford. So we are working in the field of tolerance. So tolerance is a process to try to make your immune system recognize the organ as your own so you don't fight it. So the first benefit is where it fell the first place. It should protect against all type of rejection. So that's the main deal. The second thing is if you do not need immunosuppressants, then you're not exposed to all the potential complication, which where he had the second, in a way, shortcoming of immunosuppression, which eventually took her life. So that's what we are working on at Stanford.
And you're doing some pretty cool things. I rewatched your Grand Rounds presentation from a few years back, and you use the word chimerism. So I know a chimera is a fire breathing monster with like a lion's head and a goat's body and a serpent's tail, but I don't think you're actually creating those in your lab. Unless I'm wrong, you totally could be. I just don't see the IRB letting you do that.
No, I don't do benchwork research anymore. So it's interesting. So that emblem, which is a mythologic beast, which represent the mixture of things, is actually the emblem of the American Society of Transplant Surgeons. But it represents having things from different people. So actually, when I approach the patient, you know what example I use? It's not the chimera, it's the tangelo, which is a
Oh,
chimera between the tangerine and the pomelo. I think it's less scary. But
yes,
yes,
definitely.
but immunologically, what it means in the context of tolerance, it's the mixture of two immune systems. So the only way we have been able to get patient of drugs or attempt tolerance, it was the mixture of the immune system. So it starts from the early research of Medawar in the 50s, got a Nobel Prize, that you have this mixture. So this is all based on basically two immune systems to get along. You need a process to do so, but that's
Mhm.
basically the principle of the chimera. We are creating chimeric immune system.
Cool. One name kept coming up. Who is Sam Strober?
Sam Strober, very interesting story. So
Mm.
Sam Strober is the founder or the inventor of the Stanford Tolerance Program.
Ah,
Yes, it all started with
okay.
Sam. So Sam, he passed away 3 years ago at the venerable age of 81 years old. But what is a bit odd is that he was a practicing rheumatologist. So, why did he spend all his research career try to achieve tolerance and solid organ transplant and
Yeah.
also to reduce the burden of graft-versus disease for the hematologic patient? So you have to go back many, many years. And I tracked this back. Sam was actually, as a medical student, working in the lab of Joseph Murray. So, if that doesn't ring a bell, Joseph Murray is the plastic surgeon in Harvard who did the first successful kidney transplant between twin brothers, like mid
Ah,
1955. And he received a
okay.
Nobel Prize for this. So I think he planted the seed in Sam's brain to make transplant better. So then Sam went to Oxford, actually at the same time as Earl Wiseman at Stanford. So they both came back to Stanford, and then it's all sometimes it's like pure serendipity. So
Mm.
Sam met with another great Stanford pioneer, Dr. Kaplan, who is probably the father of modern radiotherapy. He invented a treatment for the treatment of lymphoma, Hodgkin's lymphoma, which was called the total lymphoid irradiation. So instead of having the radiation given to the entire body and then your bone marrow will fail, it's only
Mhm.
directed to the lymph nodes. So Sam worked with Dr. Kaplan and eventually discovered that this type of radiation was helping to create tolerance. So he developed, like in the mid 60s, a protocol that combined the total lymphoid irradiation, which we can call TLI, with some anti-lymphocyte preparation that is commonly used in transplant. And those two things together, plus bone marrow cell from the same donor as the donor of the organ, in the mouse, in the animal model, achieve tolerance without immunosuppression.
Wow.
So he is the initiator, but he has built a big team. So as we mentioned, my academic interest in transplant is improvement of
Mhm.
immunosuppression. So I work on new drugs, but what better than no drug as a best immunosuppression? So I was able to join that team 20 years ago. So I'm part of a group, including, bone marrow transplant specialist, Dr. Lofsky, Dr. Mayer, and nephrologist, Dr. Scanling, radiotherapist, Dr. Hoppe, Dr. Susuru, that Sam would call us, we are the trialist. We are doing the trial. So he's the inventor and we're making it happen. So basically, we work on translating his research to the clinic. And we've been in the clinic for 20 years in that field.
Awesome.
At this point, we have the largest experience in the world in that field.
Well, speaking of trials, you published a paper in the American Journal of Transplantation this past July. I'll put a link in the show notes for our listeners so they can give it a read. It was a phase 3 trial, antigen matched living siblings. Can you tell me about this?
Yes. So I think this is a huge landmark. Now I have to backtrack a little bit to explain where it fits in our evolution of our research program. So first, you have to know a little bit how matching works. So we all different,
Right.
but some are less different. So me and my twin brother, we don't need immunosuppression. We can exchange, but that's quite unique.
Helpful in case you need a kidney.
Yes, we are each other's organ bank. But so next is the people who are identical at the level of the genes that are more relevant to transplant.
Okay.
These are called the HLA, the human leukocyte antigen, because this is how the immune system works. It was not built for transplant. It's how we find the difference between each other. So between siblings, because you get these genes for your parent, you have 25% chance that between the brother and the sister, they have the same set of genes. So these are the patient that we are less likely to reject. And if you do a bone marrow transplant, they're less likely to have the opposite of rejection, which is the donor takes over. It's called graft versus disease. That can also be as difficult or dangerous as a rejection. So we started with this group of patients because they were more likely to have success. And if something would happen, the likelihood to be salvaged for any complication. So we started this in 2005 and completed in 2016. So we used the protocol that we talked about, just translated from the animal to the human, which consists of the spatial radiation and some lymphocyte depletion, so reduction to favor the engraftment. And we have done 29 patients. And more than 80% of these patients, we were successful to get this mixed chimerism and to take them off drug. So some now are off drug up to 17 or 18 years. So you get a transplant, you're on no drug in a majority of patients. So we are the developer, they are the developer. So we call these like the early phase, which is like phase 1, phase 2. The next step in progression is to do a randomized study. So is this something that anybody can do, or it's only the specialists at Stanford that can do it because they have been doing this for 20 years? So a randomized study, which means that you have people that come in, some get the treatment, some get the regular treatment. So it was conducted in 12 centers in the United States, and patients had the same criteria. And they were basically given the Stanford recipe. So it was done independently of Stanford, but was based on our protocol. So exactly what we did at Stanford. And they had similar results.
That's great.
Yes, it's great because a phase 3 is the last phase before you can actually commercialize. So if it would be a drug, then you go to the FDA and then it can be given to a patient at the pharmacy. So this is more complex because it's a process, but basically the FDA had some criteria to say, if you do this is the type of success we're looking for. If you meet these criteria, this can become a therapy for patients outside of research. So that's why it's a landmark,
Mhm.
because it has happened. So the study met the criteria. So for us at Stanford, it means that we really went the full loop where it's bench to the clinic. And now, which we rarely do as universe centers, so we saw our basically innovation going to the hospital near you. Okay, so basically to make it available not to people who can only travel to Stanford, and then we need to have research fund to have it. It means that if a company would take this forward, it's a program that can be available to all patients in that segment. So, which is still a small number of patients. So, this is what we call we written the chapter one, and now we're still in the writing of chapter two, which is to address patients that are not as well matched. So we go from full match to half match, and maybe eventually to even less match than this.
Okay. So now I want to ask you about a patient that you had a few months ago, because I don't think that they were as much of a match. Stanford successfully completed its first allogenic islet cell transplantation in a patient with type 1 diabetes. And it was a whole team effort. It was Dr. Everett Meyer, who's the bone marrow person that you talked about earlier. It was IRs, Dr. Avnesh Thakur, just a whole team coming together to do this procedure. The recipient and the donor, were they any kind of a match there?
Okay, so let me give you a big picture of this.
Okay.
So islet transplant, we're talking about pancreatic islet. So
Right.
this is the missing islet, or the missing cells that the patient with type 1 diabetes have lost.
Yep.
So if you give the islet back, you should restore the sugar control and cure the diabetes. So I do also full organ pancreas transplant,
Mm-hmm.
but we don't need the full organ, but
Right.
that's very successful. So islet cell transplant is the ultimate, more precision medicine approach to the cure of type 1 diabetes.
Mm-hmm.
It has been not progressing very fast in the United States for a couple of reasons. The main one is that in the United States, the FDA considered this not as a transplant, so the regulation to be more like what you know, like a kidney transplant. They say, well, you're putting those cells in culture, and then it's become a drug. So the bar to be able to do this on a regular basis is very high and very expensive.
Oh,
So
I
that kind
see.
of slowed down the progress of islet transplant in the United States. The second part is a phase 3 trial, just like we talked, the ultimate trial in islet cell transplant has been completed more than 10 years ago. And one of the conclusions, besides showing that it is efficacious, is that most of the adverse events are related to the immunosuppression. So even the conclusion of the study is this will not become a large-scale therapy unless we have more tolerogenic approach. It's like calling us by name, okay?
It really is.
So actually, we had people in the field say, Stanford should get into this and see what you can bring to the table. So that's why you say it's been a long, long process. And actually, it took us many years. First, you have to know that at Stanford and UCSF, we are center of excellence in diabetes. There's like fantastic basic researcher and a lot of people who wanted this to happen.
Mm-hmm.
But the regulation is very difficult. So we are probably the only new islet cell transplant, and we're talking about allogenic. So allogenic transplant program that is been approved in the last 15 years.
Mm-hmm.
It was a bit difficult because you have the regulation. Then we got into COVID, so it was a lot of process development. What we wanted to bring is a bit similar to what we're doing with the kidney transplant, is to bring some donor cells along with the islets. Big difference here is we are from deceased donor.
Uh-huh.
Okay, so we're not going to have a great match,
Right.
and we will still need to develop a manufacturing process to get those stem cells. So
Mm-hmm.
which we did. So basically, you take the bones that have the most bone marrow from the same deceased donor, and you have to extract them and purify them. So that took some time, but we get everything approved by the FDA, the manufacturing, until we were ready.
Oh.
We also did not wanted to reinvent the wheel in terms of islet cell preparation, and we have great colleagues at UCSF who have been doing islet cells transplant for decades, and we were able to actually have a collaboration with them. So, the goal was, if we go in this together,
Mm-hmm.
they provide the islet cell, we provide the bone marrow cell, and we can eventually write protocol together. So, but we still needed to start with the first case at Stanford to show that we are able to do this. So
Mm-hmm.
that's where we come this team approach, where we have Dr. Takor from IR. So he's pediatric IR, but his research
Right.
is on islet cell transplant. So we had already people lined up to say, we want this, we are interested, we want this to happen. So we eventually identified a first patient. She was on the list for some time. And then one day, a suitable donor was available, and we were able to proceed to do this. So the islets, the pancreas was brought to UCSF, they prepared the cells, and we prepared the bone marrow. And then we all convene on a Sunday afternoon to proceed with the infusion of the cell, which is relatively straightforward.
Mm-hmm.
So instead of a big operation that I can do, which is like, exposing the vessels
Mm-hmm.
and connecting the bowel, the artery, the veins, Dr. Takor with one of his colleagues of the radiology intervention put a small needle in the liver, and we push those cells in the liver, and for them to sit there.
Mm-hmm.
And then we proceeded with our modified immunosuppression, and 2 days later, she received the bone marrow cells. The idea is not to do the full camera, but to get enough of these cells to tilt the balance into her immune system to accept the cells. The idea here was not to make her completely off drug,
Mm-hmm.
but minimize immunosuppression. So we're 6 months out.
Okay. How's the patient doing?
She cannot stop smiling.
Oh, good.
Okay, so she's so happy, never had so much energy in her life. She's not completely off. I think she will probably go off insulin at some point, but it's minimal dose. But she is 100% under the perfect range of control. Very good result. You have to understand that most of the time, islet transplant, you require more than one infusion. So
Mm.
to even hit the mark with only one infusion, it's less than 30%. So even for our first patient, with the help of our colleagues, I think we were able to be not at the beginning of the learning curve to position us as with the first successful patient. So this is very exciting,
Mm-hmm.
but we'll have to see how we can bring this forward, because again, the limitation. So there's a company now that is under this requirement of the ABLA that can offer cells, but the financial ramification still needs to be sorted out.
Absolutely.
So this is, I hope, a new beginning for islet cell transplant in the United States.
Very exciting. Well, that sound means that it is time for our lightning round. On each episode of Scrubcast, we ask each of our guests the same 2 questions. And the first one is, who is a surgeon you admire and why?
To me, a great surgeon is not only a great technical surgeon, is a great doctor. Being a great doctor, I include the knowledge of medicine, so well-rounded, good with the patient and the family. But I almost think this is like the standard. We should start with this. Then the little something else that make the difference between the great surgeon and the one that you may remember, and just maybe because of my inclination on, because of music or whatever, is, I would say, virtuosity. When you see somebody that you say, well, that's another league. It may be not necessary that we all like this, but if you see that in the OR, it's like the OR used to be called the operating theater.
Mm-hmm.
It's a small audience, but we're still performers. If I compare to sport, I remember in Montreal seeing a session where you had Roger Federer and Nadal and Novak at the same. They're
Sounds
all
like a
great,
good match.
but yes, but the finesse of Roger Federer kind of stands out. that thing of virtuosity, or the Horowitz or the Yu Wang of piano. So to me, that attracts me. So I would put, if you want names, I would put Carlos Esquivel there, and I
Mm.
put also my original mentor who passed away this year, Pierre Dalloz. There are probably others, but this is something that the little je ne sais quoi on top of what you expect from a great surgeon.
I love that. I totally understand what you're saying about the virtuosos of the operating theater.
Yeah.
The second question we ask is, what is the best advice you have received in 10 words or fewer?
We'll have to count the words. Give me 2 seconds. Okay. I think this is the best advice that was given to me by a surgeon before I moved to the United States.
Okay.
He said, Stephan, I'm not going to count that word. Starting at a new place, put money in the bank first.
Ooh.
What he meant, and I also give that advice to every finishing fellows, and it is build your reputation first. So before you take difficult cases, okay, nobody knows you. You have to build your reputation, and you don't take too high risk up front. This patient needs to be treated, but you may say, hey, I'd like your help first. And you build your reputation, and then you can expand on the difficulty of cases.
I like that. Very nice. Final question of the lightning round. What is your preferred OR music?
To the despair of many, I don't know anything that has been composed after 1940. Okay, classical
Ooh.
music. Okay, so, and it's not a despair because I have a lot of empathy, so I'm not making anybody suffer. But music in the OR, there's still some criteria here. One is still in the background of safety. It cannot be too loud.
Yep.
It cannot be annoying. It cannot be stressful. The idea is to reduce the stress so people can function at their level. You need to be able to hear the bells and the alarm. So we have to be, so that has to me, it's like, it still does not trump safety. Okay. Then I'm passionate as much about classical music and particularly the piano repertoire than surgery. So this is me, okay? So I would not operate well with music that I'm not passionate about. So I would say classical music, but not too, very appealing, easy for everybody, or nothing. So if I feel that this is going to annoy anybody, I rather have the music in my head. So I can tell you a little anecdote about this. One of my former fellow, who was Dr. Gallo, who you probably know.
Yeah.
Yes. So our preferred music is rock, heavy metal. Okay. So not exactly in line. So what I developed a selection with more like easy music, like, the Season of Vivaldi, a few easy Mozart, whatever, which I called the Gallo Suite. And then you know what? After a while, everybody wanted me to put the Gallo Suite on.
Nice. I like that. I like to listen to Bridgerton music, and it's classical takes on popular modern songs.
Yes, actually, I like it. Sometimes it came in the war. It's like, are we listening to the Bridgerton?
Yep.
But I kind of like it.
Yes.
I would probably, it's just because I don't have the time to discover other type of music. But when my son comes home, I would just take his music selection, bring it to the OR, and I would be fine.
Perfect. Well, it has been such a pleasure chatting to you. Before we go, one last question. What is next for Dr. Busque?
So next, I think it's all putting it together, these 20 years of experience in tolerance. And I think we are in a acceleration phase. So chapter 2 is almost written with the half match. We are going to open liver transplant tolerance. We have already protocol for deceased donor transplant. So I think in the next 5 years, we should see significant improvement in that field.
Awesome. I'm looking forward to every minute of it. Thank you so much for talking to us.
My greatest pleasure.
And thank you to our listeners for tuning in to this episode of Scrubcast. Until next time, stay sharp. If you like Scrubcast, we hope you'll tell your friends and subscribe wherever you get your podcasts. Scrubcast is a production of Stanford University's Department of Surgery. Today's episode was produced by Rachel Baker. The music is by Midnight Rounds, and our chair is Dr. Mary Hahn.